All right, welcome to the next installment of Live Well with UCI Health. I am Ryan Manno from Coast 103.5 iHeart Radio. Pleased to be joined today by Dr. Hari Keshava, fellowship-trained, board-certified thoracic surgeon who specializes in the treatment of lung cancer.
Thank you very much for having me. Thank you.
I'm not done. No, doctor.
Okay.
No. You didn't do all this work for nothing. He's an assistant professor in the Division of Thoracic Surgery at the UCI Irvine School of Medicine and a member of the American College of Surgeons and the Society of Thoracic Surgery.
Thank you very much. Thank you.
God.
That was a great introduction.
Thank you, sir. It's a pleasure to have you here. And really quick, one before we get into lung cancer and all this stuff, we've been doing this for a while. No doctor has ever come and sat with us and said, I just got out of the operating room. But you did.
That is true. I just got out of the operating room.
Unbelievable.
This morning and changed, did my hair.
Yeah.
And came here, put on a coat and came here for this. So I'm excited to be here, and
that's great.
we're excited to be doing this.
Yeah. So let's talk about lung cancer. It is the leading cause of cancer-related deaths in both men and women in the U.S. Why?
So yeah, you're exactly right. It is the leading cause of cancer-related death. And the main reason is, unfortunately, with lung cancer, we don't really do a good job of finding it early. When I say that, I mean, as a society, there's no real good symptoms for lung cancer. So if patients have symptoms, whether that's a cough or they're coughing blood, let's say, these are usually later stage. They're found later in cancer screening and lung cancer screening. Unfortunately, with the screening, we're not screening as many patients as we'd like to early enough, so we can find it early and potentially deal with it early. So that's unfortunately the real reason why lung cancer is the leading cause of cancer-related death. And of course, we've had a lot of people in our country who have smoked and who still currently smoke, and that's the leading reason for developing lung cancer.
Mm-hmm. But there is hope, right? There is hope here. I know a lot of the advancements you've made, but let's talk about the screening. Who should be screened and when?
So for lung cancer screening, we do it with a low-dose CT scan, which is a scan of the chest, where we look for lung abnormalities, lung nodules, lung masses. For patients that are 50 to 80 years old who have smoked in the past, we call it a 20-pack-year smoking history. And when I say smoked in the past, meaning within the last 15 years, or are current smokers, for those people, we offer lung cancer screening, and that right now, those are the patients that we screen.
Okay, got it. And what is a pack year?
A pack year is essentially, it's a pack of cigarettes per day for a year.
Okay.
So it's if a person smokes, I say I smoke a pack a day, and I've been doing it for 30 years, we say that's a 30-pack year smoking history. And let's say someone says, oh, I smoke a half a pack a day, and I've done that for 20 years, they say there's a 10-pack year smoking history, because now it's half a pack times the number of years.
Got it.
But as you may imagine, or as you can think about it, there's so much of a recall bias there, because some people will be like, oh yeah, I smoked a pack a day, and then I stopped smoking for a couple of months and started smoking a half a pack. So it can be really difficult for patients to tell us like how much they're actually smoking and to really quantify that, especially cigarettes. And then, of course, people might not realize or remember how when they first started smoking, or, hey, I started in college and I stopped a little bit, then I started back again when I had some stressful times at work. And so there's all these start and stops. So they might not remember when they actually started smoking. So these are some issues that come about with this.
And I would think, too, I mean, some people may even try to downplay it because they don't want to admit that this is how much they've smoked or something.
So you bring up actually a very interesting point, and this is actually a big issue also with lung cancer screening, is that we have a stigma behind it.
Right.
We have a stigma because of like exactly what you said, where people will feel a little bit of shame. They're like, oh, I kind of did this to myself, or when I smoked and I feel bad, they might downplay it. So we see this actually in a lot of populations. We have a lot of different people we treat here, people from other countries, Vietnamese, Chinese, but we also see this in the veteran population. And that's a population, of course, where, if you remember, we used to actually give people cigarettes to smoke, right, when they went to Vietnam War. And we used to give them cigarettes because we didn't kind of know any better as a society. So I think that shame part of it is is now we should not think that way. It's not a shameful thing. We actually want to be able to help patients and screen them, find cancer early.
Yeah.
We know it's a cancer causing agent, especially with cigarette smoking. So patients shouldn't feel shame from this.
You're not there to like judge them. You're there to find it and fix it.
Exactly. You're exactly right. We're not here to judge.
Yeah.
We're not here for any of that. We're here to find it early, because if we find it early, we can deal with it, right? I'm a surgeon.
Yeah.
And if we can find it at stage 1, I can remove it and potentially be cancer-free.
Yeah.
So that's the goal here.
Yeah. And it is wild. You bring up, how we used to give people cigarettes. I mean, I can picture old magazine ads, like the 8 out of 10 doctors recommend, Camel or whatever. It's like, what? How far we've come.
We've come a long way. And I remember if you could even talk to some of the older physicians, people used to smoke in the hospital.
Oh my gosh.
I trained out in Cleveland, and they had areas with ashtrays like outside of patient rooms. So we just didn't know much about it, right?
Yeah.
We thought it could help with various different issues. So we've learned a lot about it. We've learned how it is a carcinogenic substance, especially cigarette smoking. So now we know we should be screening those patients.
Get screened. How often should people get screened?
So patients should get screened every year. If you're between that 50 to 80 years old, you smoked for 20 years, 20 pack years, you should be getting screened every year.
Okay, in terms of the screening itself, what is that process? You come in, you're getting screened. How long does it take? What happens? What's the process?
It's a good question. So with screening, as we talked about, it's for patients that are 50 to 80 that have smoked for 20 years, 20 pack years, and are current smoker or quit within the last 15 years. So that's the criteria. So when you get screened for lung cancer, we do a CT scan of the chest. So what does that entail? It's in the hospital, or it's in an imaging center where you go and you sit in what's called a CT scanner, which is not a claustrophobic like MRI. It's actually pretty open. And they do a quick scan using really, really low dose radiation to see the chest, the lungs, and they even look at the chest wall, everything from essentially the bottom of the neck to the top of the abdomen to make sure we get the whole lungs. And that CT scanner is a really quick scan, about 30 seconds.
Oh my.
And maybe if they have to redo one of them, they'll be a minute. It's kind of in and out. And at that point, they can look at lung nodules, lung masses, the lungs, even the heart. We can look at other structures, potentially other issues, chest wall issues. Specifically for lung cancer, we look for those lung nodules, lung masses, and we can see both lungs.
So it's non-invasive. It's not scary. You don't even feel it. It's in and out.
You're exactly right. It's non-invasive. It's not even like a blood test.
Yeah.
It's in and out. It's a low dose CT scan, meaning low dose of radiation. So when we talk about radiation exposure, it's the equivalent of a plane flight from LA to New York. It's about that much radiation exposure, so pretty minimal, but we get a really good understanding of what's going on in your chest and in the lungs.
Moving away from cigarettes and smoking, what about some other factors, right? Like, even secondhand smoke or environmental, whether it's pollution or exposure to radon or things like that.
You're exactly right. So you bring up other things that can cause lung cancer. So secondhand smoke, we do know about it, especially if you've had a large amount of secondhand smoke exposure. Radon is the second most leading cause of lung cancer. And we see this a lot in patients that grew up in the Midwest because they have a lot of radon that's coming from the soil there where houses were built. So that's something we do see. We're actually learning a lot more about familial inheritance of lung cancer and familial lung cancer. If you look at some other countries out, like especially in Taiwan, they've done a study out there where they actually found that outside of smoking, that family history of lung cancer was a leading reason someone may develop lung cancer.
Really?
Correct. Yeah.
So let's talk about that for a second. The host of the show that I host, Ellen Kay, she lost her mom to non-smoking lung cancer. So are you saying that's potentially a genetic thing?
It potentially is. In the Taiwanese community, they actually found a gene, this EGFR mutation.
Okay.
And we see this amongst a lot of Asian populations, or amongst not even just Asians, but amongst other populations, where they found that there is a familial component to that.
Wow.
And we're actually studying that now at UC Irvine. I actually have a study where we are doing a clinical trial of screening with a CT scan of non-smokers. But if they had a family history of lung cancer, we'll be screening them now to see if there is this familial component even here on the West in the United States.
Yeah, fascinating. Since you guys have, and I say you guys as a collective, doing what it is that you do, since these screening tools have gotten better and progressed and people are doing it earlier and doing it more often, have you noticed an increase or seen a decrease in deaths?
We have actually, and this is not just from screening actually alone, but with lung cancer in general, we've actually seen a marked improvement of survival even over time. So we're finding it early. We're doing a better job of screening people. We actually have better treatments now also as well. So as a surgeon, I do a lot of minimally invasive robotic surgery so we can get people out of the hospital very quickly, do some advanced surgeries, even minimally invasive. Mm-hmm. And on the other side of it, we've gotten very good on radiation techniques when patients might need radiotherapy or radiation therapy. And of course, chemotherapy and immunotherapy. You've probably heard about chemotherapy agents, newer ones. There's newer immunotherapies and these targeted agents where we can target the genetic mutation that the patient may have for their cancer. Yeah. So we've gotten so much better from the treatment standpoint as well as the detection. Mm-hmm. So now people are living longer with lung cancer.
What was, before some of the stuff was there, what was the most common way to treat lung cancer prior to all of these wonderful things you just described?
So it would just be kind of the generic chemotherapy. So it wouldn't be anything that was very specific to a patient. Now we talk about patient-centered medicine, patient-centered care. Before, it was just you take whatever you can get and you just give it to the patient. Hopefully it works. But now if we can find it early, get it out with radiation or surgery. Mm-hmm. If we can test it, we do genetic testing of the tumor, then we can actually find a targeted treatment for the tumor. Mm-hmm. And we have more specific agents. So I think we're getting to this more patient-centered care, which is great for patients.
Yeah, and it's got to be exciting for you as somebody who's given your life to treating this, like to find these things on the horizon that are still coming.
Oh, it's amazing to see. Even since when I finished my training and started here at UCI, during this time, I've seen care change tremendously, where I'm seeing patients with stage 4 lung cancer that are living long enough to now come and see a surgeon, or where I'm taking them out. Sorry, when I say them, I mean taking the cancer out. I'm taking the cancer out and seeing them live a long time because I took it out. They got on a targeted therapy. And so it's fascinating to see lung cancer care change this much.
Yeah, that's so cool. And that's got to feel so good. I'm so in awe of surgeons and what you guys do, because the satisfaction that you must have when you look at someone and you save their life.
That is exciting. That's
one of the chills. I literally have goosebumps.
And it's we do a lot of teaching and training here, right? We teach medical students, we train residents and fellows. That's actually one of the joys of what we do is actually showing the medical students, showing the residents and the trainees that, hey, after we remove the cancer, I see them back in clinic.
Man,
next week, 2 years later, they're doing great with hugs and these types of things. And I think it resonates with the patients, with our trainees, with me, of course. And like you said, it gives me goosebumps every time I see a patient, like let's say 2-3 years out, cancer-free, and just doing the run-of-the-mill checkup type thing.
What a cool, oh gosh, that's awesome. So let's talk about you get screened, there's a nodule detected, or you see something. What are the next steps there?
So before we get to that, I'm actually going to talk about getting screened. Any physician or primary care provider can screen. Okay. So if you're a patient, hey, you've smoked in the past yourself, or your family member has, you want to get them screened. They're 50 to 80, smoked over 20 years, a pack per day, get screened. So your primary care doctor could do it. Or we have like a lung nodule program. If you don't know where to go, we have a phone number, or a lot of places do, but we have one where you can call and you get to one of our providers and they'll get screened. Now, after you've gotten screened, if you have a CT scan with an abnormality, like you said, a lung nodule, a lung mass, or any other abnormality, then you can kind of now see your primary care, or you go see like a pulmonologist or even a thoracic surgeon. Right? I get a lot of people that come and see me that have a lung nodule. At that point, we kind of look at it, see If it's something that looks a little bit more suspicious, we might go for a biopsy. After having a visit, a biopsy, we can either do that bronchoscopically, where we go through the airway, or we do a needle kind of from outside in, try to get some tissue to get a diagnosis. And if we get a diagnosis of cancer, then we go forward. We'll get some more scans, potentially a PET scan. Potentially you'll see me for a surgical resection, or potentially even my oncology colleagues if you need some sort of chemotherapy, immunotherapy. And we'll kind of go from there.
Yeah.
Patients can have lung nodules for a multitude of reasons. It doesn't have to be for cancer alone. You can have it for fungal infections. You can have it for what we call granulomas, which are benign entities. So we got to make sure we're dealing with cancer, of course, first and foremost.
I'm just thinking back again. I shared that story about Ellen K's mom, and for years she was part of various clinical trials, experimental things. Can we talk about the importance of clinical trials?
Yes, of course. Clinical trials are crucial for the treatment for patients and also for the advancement of the field, so that you kind of get a 2-for-1 there. What does that mean? So we're a comprehensive cancer center. So we have different providers, like let's say for lung cancer, you have a surgeon, a radiation oncologist, an oncologist, but you also get palliative care, physical therapy, all these types of things. So we can provide all of that. On top of that, we also we have clinical trials. That's what kind of really sets some of these cancer centers apart.
Yeah.
Is these clinical trials can be really focused on the patient, specifically to their own cancer. If they have a certain genetic mutation, we can have trials for that. And these trials give patients an options for treatments. They also, like I said, help further the field because we learn more about it, make sure it works well. But it really is part of the care for patients with cancer now. More and more and more, we have clinical trials from all different stages. We have surgical clinical trials to targeted therapies, immunotherapies, radiation. We even have Reiki. We do all these things. Yeah, we're doing Reiki for patients with maybe pain or chronic pain.
Wow.
We try Reiki therapy. So we have clinical trials in all these things.
Yeah.
And so this is something that I really talk to them about talk to clinical trials about talk to patients about these clinical trials because I think it's something that can really help patients.
Do you find that when you bring that up, when you start going down that road, do you find willingness or hesitation?
Because I think both.
You do? Okay.
Yeah, I think both.
Yeah.
I think some people are really inclined to go through clinical trials, like you bring up Ellen K, who I've also listened to growing up in LA.
Shout out Ellen.
Yeah, a long time. That's great, and I'm happy that she was able to kind of be part of this and from the clinical trial standpoint with her family. But some patients are all about it.
Okay,
we get people that read about it. They know friends and family or friends and friends of family that have gone through clinical trials. They understand it. They read about it on the internet, which is fine, which is great. And there's some people that are really hesitant, right? There are some populations of people that might just be skeptical about clinical trials. They feel like they're being experimented on. There's that entity.
Sure.
I think this is something that I really explain to the patient, right?
Right.
I talk to them about the pros and cons, why we're doing it, why we do certain clinical trials. And some people are really for it, or if they weren't before, now they are.
Yeah.
And some people, you know what, I just don't want it. And that's fine. I think that's the beauty. Patients can choose to be part of a clinical trial or not. And if they're not, we still treat them. We still treat patients all the time that are not part of clinical trials. And if they are, they get potentially newer treatments that we're going to be out in the future.
Yeah. It's exciting what you guys are doing at UCI Health. What would you say, doctor, to, I don't know, anyone maybe that's watching or has a family member who did smoke and is hesitant to get screened or to even go down the road of maybe I should?
Yeah, I know it's difficult. And I think we brought up that shame issue. I know people think that way, or they think, oh, there's nothing wrong with me, or I don't care. There's nothing I could really do about it. I think people got to understand there is something that can be done. You shouldn't feel shameful about it. If we find it early, even if you don't want surgery, then you can go to radiation. If you don't want radiation, we can go to surgery, right? There's so many options that we have. There's really no downside, I feel. And just a screen is just a CT scan. It's literally, you just go, you sit in not even a tube, it's just like a quick scan. And we know a lot about what's going on in your body. We know a lot about if you have a lung nodule or not, if you have a pneumonia potentially. We can take care of that.
Yeah.
So I think there's really, really minimal downside and a lot of upside to getting screened.
And it's so fascinating. I think when you really think about breathing, we take it so for granted. You know what I'm saying? Like it's one of those, you have to do it. No one's ever like, I'm so happy I'm breathing.
Yeah.
You know?
It's one of those things you don't think about it until you have problems, right?
That's it.
And unfortunately, like we talked about with lung cancer, when you start having problems, the likelihood you're at a later stage is higher, right? Then you might not be seeing a surgeon because it's not in a earlier stage.
Yeah.
So these are the problems. That's why you might not have symptoms. A lot of people say, oh, I feel fine. I'm going to work or I'm still working out. I'm not on oxygen, none of these things. So I don't need to be screened. That's the problem. There's no symptoms here. So we have to be able to find it early, even when you have no symptoms, when you're asymptomatic.
Because at that time it's there, but the symptoms don't present until later.
Correct. And if it's still there, we can do something about it earlier.
Wow.
So that's the main thing I tell patients, like we can do something about it earlier.
Yeah. Really good. One other one we didn't bring up, and maybe you have thoughts on this, is I know that, vaping has become like a really, popular thing now. What are you seeing with that?
That's so you bring up a very interesting point, especially in the younger population. We are seeing a lot more people that vape, e-cigarettes. Currently, we don't have enough data.
Okay.
And unfortunately, that's the problem with data, right? It takes a long time to have enough data to really extrapolate what's happening, especially from a cancer standpoint. That being said, we know tobacco is a carcinogen. It can cause cancer. Where other non-cancerous issues that do happen with vaping, there's a lot of what we call vaping-related lung injury, where it's a diffuse lung injury where we see even really young patients have lung injury where they're in the hospital needing oxygen, otherwise healthy people. So we do know that there are problems with vaping, that there can be issues. Specifically with the lung cancer, I think we're learning more and more about it. We're learning how much do people vape even? I think just even quantifying that, right?
Right.
You see these kids, they're just going.
Yeah.
And what does that even mean? Is a cartridge the same as a pack? I think these are things we're learning more and more, especially from the exposure standpoint. I could tell you it's probably not good for you.
Yes.
I think that's probably safe to say right
Yeah.
there. But from a true lung cancer risk, we're learning more and more. And especially if you have had lung cancer, you smoked in the past, and you're trying to quit using vaping, I think it's great. But hopefully you can get to that quit standpoint. But if you're just starting up vaping, especially for the young people out there, I hope I don't see you in the future as a patient. But I think we will be seeing more and more of that in the future. And unfortunately, we might be seeing more later stage, just because of the way I think it is with vaping.
Interesting. Well, you guys are doing great work at UCI Health. Thank you so much. This has been fascinating. You're great, and I know you'll continue to do great things and help people breathe easier and better.
Thank you
and
very
live
much.
longer.
Thank you. Yeah, it's the goal here. Thank you very much.